Just going to welcome everybody back from our brief break. So I'll just share a little bit about what we have coming up next here. We'll have for the remainder of our session today, in the Canadian context, is the final three presentations of the Café Scientifique, and we'll have Dr. Jagbir Gill, Dr. Caroline Tate, and Cindy Moriarty, who will be presenting. So all three of them will each give a 20-minute presentation, and then after the three presentations, we'll open up a discussion at the end for people to ask questions and have a bit of a panel Q&A session with everybody. So again, feel free to put any questions that you have into the comments leading up to the Q&A session, and I'll peruse the comment section and get some lined up for the Q&A portion. So Jag, do we have Jag on here? There you all. There we go. I see you. Hello. So our first speaker is Dr. Jagbir Gill, who will present on working with Indigenous people in transplant medicine. And just to give a brief bio for Jag, he is an associate professor in the Division of Nephrology at the University of British Columbia. His primary clinical focus is on renal transplantation, and his research interests include transplant epidemiology, database analysis and access to transplantation, as well as expansion of organ donation and the impact of donor status on post-transplant health outcome. Dr. Gill leads the Bridge to Transplant program, a BC-wide program to ensure rural and remote Indigenous communities have equitable access to get and give organ donation and transplantation. And I'll also just add that it's been a pleasure to know Jag as well over the past few years and get to work a little bit with him as well in the work. And so, Jag, I'll pass it over to you, and thank you for being here with us today.
Thanks very much, Craig. Thanks, everyone. Thank you, Carolyn, and the organizers for the opportunity to share our work with you. I was asked to speak about working with Indigenous people in transplant medicine today, and I'll do that in kind of an overview, but also in the context of the work we're doing here in BC. I have the privilege to live and work in the ancestral land of the Musqueam, Squamish, and Tsleil-Waututh nations here in Vancouver. I'm a settler here. I'm the son of immigrants who settled here. And have a South Asian background. And my kind of interest in this work in wanting to delve with this issue has actually stemmed from a lot of my own personal experiences in terms of equity and wanting to kind of address those issues in the area of healthcare. So it's a real pleasure to be here, part of this group. So I thought what I'd go through is start very briefly with kind of current state of affairs. So what is the current standard? You know, we've heard a lot of the issues from our esteemed speakers this morning already, and so I won't go into it in too much depth, but I do want to just give a very quick outline. But really, most of the talk's going to focus on how do we integrate Indigenous health into transplant medicine? That's really the question, and we'll use Bridge to Transplant initiative, the project we're doing here in BC, as an example of how I think we can move forward and what that means for the future. So I won't show a lot of statistics because I think, you know, we show a lot of stats, but I think the reason I show this is just because it just really cuts to the bottom line. So the first thing I want to tell you about this data is I'd like to point your attention to when it was published, which is 2013. So this is the last kind of current data we have, which is 10 years ago, which is one of the challenges we face right now. But you can see here that if you look at Indigenous communities or Indigenous patient populations versus the rates of kidney disease in non-Aboriginal as listed here populations, it's much different, right? Like a much higher incidence of kidney disease among Indigenous communities, as we know. And that's true in both men and women. When you look at transplant access, essentially here, what this is looking at in the top here is this is just looking at the percentage of people that have kidney failure. So they're either on dialysis or they have a transplant. And what you see here is that for non-Indigenous patients, or it's about 40% of people that have kidney failure have a transplant. But if you look among Indigenous populations, it's close to about 20 something percent, 25, 27%, much, much lower. So that's really the crux of the issue, right? We don't need a lot more stats than that to say that this is something that needs to be addressed. As we've heard from our speakers, the challenges that span this issue that lead to this, it spans all aspects of healthcare. And I think as we've heard earlier today, reworking the entire healthcare system across the entire country is, needed, but is going to take a while. And so the approach we've taken here is to say that, well, that's fine, but that doesn't mean we sit back and don't do anything about it. We need to push ahead and we need to start changing things right now. And so the question is, how do we incorporate Indigenous health into transplant medicine? And so here's kind of some thoughts on the approach we've taken. And so the first thing is, it has to work in partnership with patients and community. Far too often in healthcare, we've come up with solutions on our own in the healthcare system without really engaging or asking the people who are most affected by this and who have probably the best solutions, which is patients and community members. So that's the first piece. And that's why forums like this are so critical. The second thing is we have to have a clear purpose. Because the issues are so complex and they span so many things, we kind of have to be very specific about what is it we're going to try to address with this specific project and how are we going to move things forward. And so and they have to be practical. They have to be things we can actually change at this point and then identify other issues that need to be addressed after that. And then the last piece is also kind of a practical one. We have to respect the diversity that exists within our communities, within Indigenous communities, within our provinces, and between our provinces. And so, I think it's probably not going to be a one-size-fits-all solution for everything. And it's totally reasonable to start within your region to say, we're going to do a project, we're going to figure out one issue here. But then what we need to take with that is develop a national standard. And what I mean by that is we can demonstrate how to do it in one region and then figure out what would work or wouldn't work in a different part of the country. And our approach should be standardized. And so there's a need for a national lens on this, but it's okay for us to start within our own communities. And I think it's actually important that we work within our own communities because a lot of it is partnership within those communities. So with that, I'll turn to kind of how we approach this practically in terms of the Bridge to Transplant initiative. So this is a project that I'm very proud to be part of. We got funding for this from the Canadian Institutes of Health Research. This is a strategy for patient-oriented research project. And we started it just before COVID. And then COVID happened and it slowed things down a little bit in terms of our ability to get things going. But we kind of flipped it, thankfully, and we're able to use that time to get more information and more background so that we could go about things in a better way. So this is what this project is about. This is the baseline background as to what we were trying to address. So as I said, we want to kind of be clear on what our purpose is. So our purpose was to help Indigenous patients access a living donor kidney transplantation more often and faster. So why living donor transplantation? Well, because we know that if you look at all the options for someone who's facing kidney failure, this is by far the best option. It's better than a deceased donor transplant, and it is the best option that we can offer people. And it's also where we see the biggest differences among Indigenous and non-Indigenous patients in terms of their ability to get these transplants or their, how well we do a job at the transplant programs to get these done. So this was the focus: is let's get living donor transplants sorted. This is just a very snippet of how long it generally takes in our province right now. So as we've heard from the stories, if once you did get kidney failure or you're approaching kidney failure, you have to go through a whole series of tests to make sure that transplant's the right option for you. That can take a long time. But in addition to that, you're dealing with your own health. You have to, as the patient now, say, I got to understand what this living donation thing is all about. And then I have to do some outreach and go out there and talk to people about kidney donation and whether they're going to be donors. And then those donors themselves have to go through their own process. So there's two pieces here I want to get to. One is there's a lot that's put on the recipient to figure out. And then there's a lot of workup that has to be done, and all that takes a lot of time. So the average time is at least a year to get all this stuff organized. And so that means if we're starting here late, we're going to miss the boat in terms of these opportunities. In terms of BC, we have about 1 in 10 people affected by kidney disease in our province. There's about 3,500 people on dialysis, and we do about 340 kidney transplants per year. In our province, if you looked at everyone on kidney failure, we're actually, a little bit better than the national average, where about 40% of all kidney failure patients in the country have a transplant. In BC, it's closer to 50%. And so half of the people that have kidney failure in this province have had a transplant. In terms of how we're organized, I don't need to go through this in detail. It's just to show that there's lots of different organizations that are involved in kidney care and transplant care in BC. The one lucky thing we have in our province is that they're all integrated. And so there's a provincial organization, the Provincial Health Services Authority, and all these organizations work together and kind of work across the different health authorities in the province. And so there's an ability for us to have a pretty good relationship with the referring centers. So this is what it looks like. This is a map of the province. This shows you where the different health authorities that are listed here. There's 5 distinct health authorities. And this is on this map here, this is pointed out where the different kidney clinics are, where people get kidney care. So you can see in the north, not a lot. There's just really a couple here. Vancouver, there's a fair bit. Interior, there's a few. And then Vancouver Island, there's a couple. So it's pretty spread out. And that's part of the challenge. And so this is where patients are developing kidney disease. This is where they're living. And then they need to get a transplant. In order to do that, all of them need to end up here, which is in Vancouver. So the 2 transplant centers in Vancouver are where I work, which is St. Paul's Hospital, and then at just down the street from here, which is Vancouver General Hospital. And all the organ transplants get done here, and kidney transplants at both of these hospitals. So you can imagine what the issues are going to be for people who live far away. So the goal here for this study was to say we're going to improve access to living donor transplant, but the focus is going to be on what we do in the healthcare system. So we went into this saying we're going to change the way we deliver care to address some of these issues. And what those specific changes are, we're going to be guided by what our patient partners and community partners tell us. And that was the approach we took. So this was our team. Our patient partners were Elisa Asu and Adrian Charlie, who are a donor-recipient pair who have done so much work with us from the very beginning on this. In fact, I wouldn't think we would have gotten any funding if Elisa hadn't spoken at one of the funding events to try to get this funding. And I think that's the power of patient partners, is that if they're leading it, then things seem to kind of fall into place a bit better. This is the other partners we had, and this is our team. So the first phase was kind of getting some background work done and saying, who do we need to get information from? So we did focus groups with patients who had kidney transplants, were waiting for a kidney transplant, living donors, and Indigenous elders from our communities. And then we engaged with all the key kind of stakeholder partners as well. And based on that, we had a couple questions. We first said, well, what are the key barriers that patients, donors, and our elders in the community are identifying? And these are some of the themes we've heard already today. So there was a lot of discomfort in approaching anyone in their community about living donation. Patients are hesitant about that. There's a sense of kind of hesitancy with that, which is not uncommon, but seems more pronounced. Importantly, the willingness to donate was not a major barrier. The culture of giving and the desire to help community and help members in your community was very strong. Education was a big deal. So the education on the benefits of living donor transplant and is limited. Our tools are limited, and I'll get to that in a minute here. But actually, the thought was, and the consensus was, is that with some information and with more education, there's a sense that we really could increase living donations and increase transplants within the community. Importantly, who is providing information and how is key. And we were asked to include more people, such as trusted individuals like elders, so that the person facing kidney disease can see a trusted face and voice. And lastly, of course, engagement of the community was needed. In terms of specific health service barriers, the first piece, just continuing with the theme I just said, was education. So we took all our educational materials and said, hey, this is what we do. What does it look like? And it was a resounding, this doesn't work very well. So the educational sessions in hospital that we do were felt not to be culturally safe. That's not considered a safe space, given the history that we know. There were instances of unhelpful and sometimes condescending educational interactions with healthcare staff. Written materials, which forms the bulk of what we traditionally do, was not felt to be helpful in terms of, brochures and those kinds of things. And our elders pointed out that verbal communication, particularly, if it's in person, but even if it's digitally, would really be the best way to move forward. In terms of how we look after patients, there was a real sense that there's not a good longitudinal relationship with Indigenous communities. We do projects, we engage with community, and then we walk away. That's the perception that exists, and that we're not engaged enough on a long-term basis. And then the last piece, which was obvious, is travel. And navigating this whole system was considered a major issue. Now, highlighting, these were kind of specific things. The kind of underlying thing that stemmed a lot of this was the overt systemic racism, bias, and lack of representation in our healthcare system. And so this came up multiple times, and this is not a new issue. This is something we know that exists in our healthcare system, and it's something that contributes to a lot of the barriers when a person's kind of trying to work their way through the system. So what did we take away from all this? So there was a few key takeaways. We needed culturally relevant education that needs to be not just available, but we need to actually actively provide it when we're seeing patients. That was the one piece. The second was that when we're telling people about transplant and what it involves and how it works and what tests you need to do, we need to include lived experiences and storytelling in that, and that's got to be the way we approach it. We were told that the whole transplant donation evaluation process is not simple, as we know, so we need to simplify it as much as possible, and we need to provide navigation support that is culturally safe. Lack of representation is an issue, and we need more transparency in the system. We have to address systemic bias and racism by making it very clear who gets referred, who gets seen, who gets approved, and we need more transparency around that. So here's what we did with that information. We had a consensus workshop, which included our Indigenous patients, elders, and healthcare providers and other key stakeholders, brought this information together and broke it down to kind of key things that we think we can start with and changing. And here's where we landed. So the first two components are what we're working on right now, which is culturally tailored education supports, which I'm going to talk about, and Indigenous patient navigators to help guide patients right from the get-go all the way through the process. And the goal is that should improve access to transplantation. And then the other part that goes with that is having a better post-donation follow-up care so that it's tailored specifically so that we actually have more supports there. And of course, ongoing, we are working on cultural safety awareness and ongoing engagement to maintain that long-term relationship. So let me tell you a little bit about the education piece first. So as we heard, storytelling is a big piece of this. And so storytelling can be used in a few different ways. It can be as a source of peer support. It can be used to actually provide expertise from people who've lived it and talk about the experience. And it can be useful for kind of looking at recommendations of how to navigate the process as well. So we have now looked at what other storytelling websites and things are out there. And so the Explore Transplant's one from the United States by a colleague named Amy Waterman. And this has been a good system. There's been other programs by the Canadian Blood Services. Craig's been part of it. Other members have been part of this, and they've been very helpful. But looking at this one in the US, some of the challenges that these websites has is that generally there's a lack of diversity among the storytellers. And in a study that they did in the US, they said that they had difficulty recruiting minority storytellers, and they didn't have a lot of in-depth engagement with the storytellers. And so that was part of the problem, right? Is that these exist, but they're not really hitting the right patient population. And so what we're developing right now is a virtual navigation website that uses primarily storytelling. So the idea is there's a website, a patient will go, they'll select what they want to learn about. which part of the process. It'll be very easy to navigate, and it's all video only. So videos are a combo of patient experience, and then the gaps in terms of content are filled in by transplant professionals. And then there's an option to link for more text information. So I'll show you what this looks like. This is just a mock-up, so it's bland in terms of colors. We're working with Indigenous artists to make this, look a bit more culturally safe, but this is just to give you an idea. You would come to this kind of virtual navigator. This is for both patients who are looking for a transplant and for people who are thinking about living donation. So you just pick, I want to learn about kidney transplantation, for example. You'd go through and these options would show up. So someone might say, I want to know what are kidneys and what is kidney disease. And then that takes you to a video where here we've got Grand Chief Stewart, who was kind enough to help us with some of these. And it's about a three minute video where Grand Chief Stewart or another patient partner talk specifically about what are kidneys, what part of that story that's relevant. And then intermixed with that is someone like me or one of my colleagues talking about some specific pieces, and then any diagrams that are there that are culturally safe in terms of the diagram. We've got Indigenous artists developing these for us so that we can kind of give a patient a snapshot of what it is. And the idea is that this will be used in our clinics. So when a patient's getting educated, we'll talk them through it. The way we've gone about this, hopefully, is culturally safe. That's been the intent. So we're working with an Indigenous web design company. We've got Indigenous filmmakers involved in this process, and we've tried to make sure that we're covering all the gamut in terms of the stories. And importantly, this is a website. This is going to be used not just for Indigenous patients. The idea is that we're using Indigenous ways of knowing and storytelling to address every patient population, believing that is beneficial for all. And that was the direction that came from our Indigenous patient partners. These are just some of the different stories. This is Elisa, Grand Chief Stewart. This is one of our elders in our community and our filmmaker who's been working with us. And so that's the education piece. The other piece I want to talk about is the navigation piece. So how do we help patients through a navigator work through the system? So basically, here's what it looks like. And right now, you've got the referring centers where patients with kidney disease are around the province. They don't do transplants there. And they have their own hospital-based Indigenous wellness teams. And right now, the transplant centers have their hospital-based Indigenous wellness and navigation supports. But these supports are generally only for people who are admitted to hospital. They don't do anything outside the hospital. And so that's what we need to change. So what we need is a transplant Indigenous patient navigators, somebody who is Indigenous. They're working with the wellness teams, but they're actually only focused on transplant because they have that knowledge. So that's who we've hired now and have implemented here at St. Paul's. And they're integrated both with the wellness team and the transplant center. They will communicate with a regional center so we get more information, and they'll support patients through their journey. So that was the idea, but it became very clear that a transplant Indigenous patient navigator can only help patients if they've actually been referred for a transplant. So that opened up another area that we need to fix right away, and that's the referral process. And so currently, it's up to the discretion of referring programs to refer a patient to the transplant center in Vancouver, and we just take that at face value. And so that's a process we're currently changing. And essentially, it's an opt-out referral. So what do I mean by that? That means if a patient identifies as Indigenous, we're asking that whether that person's a transplant candidate or not, we want to know about that person at the transplant center, and we need an explanation as to why you think a referral is or is not warranted, and we're going to review that ourselves. We'll have a centralized transplant referral review, and we will provide guidance to say, yes, we agree this is not valid. This person's a 95-year-old, and clearly transplant's not an option in that case, for example, or we say, actually, I'm not so sure, we need to do something more here. Importantly, this transplant referral review will include members from the Indigenous wellness team, and transplant navigators will be part of that as well. So we'll make sure that those are representative. And once we kind of decide that somebody is maybe not clearly, if someone's not obviously, not a transplant candidate, if there's a chance that transplant's an option, then we're going to see them soon. We're going to not wait till they start dialysis, ideally, and we want to provide there'll be a virtual option or in person, whatever works, and we'll meet with them with our Indigenous patient navigator to either provide education and support. So if someone's really early and they just want to get some more information, we'll get in there and start talking about that right now. If someone is further along and we think that we really need to work them up and get all their testing done, or there's a medical issue that needs to be sorted, again, we want to start that early and start doing a medical assessment right up front. And then our navigator will provide navigation support right from the get-go. So you can imagine this is someone who's not even on dialysis yet, and we're going to start this process and go through it to say, how can we help you find a donor? And we can address any of the barriers that we can have and use some of those education tools that we're creating. So the goal here is to improve transparency and navigation support. So anyone who self-identifies as Indigenous, that's First Nation, Inuit, and Métis, and they have kidney failure in BC and Yukon, the following should happen. They're going to have their chart reviewed for transplant without exception by the transplant team. They're going to be assessed early so that they have time to get comfortable with the idea of transplant and we can help them better in finding a living donor. We'll have the support of transplant Indigenous patient navigators from the very beginning, and we're going to have medical testing coordinated to minimize travel and delays. So that upfront early meeting will help us figure out, okay, well, where do you live and where can you get testing done? And if it's faster to just come down to Vancouver and get it all done, then we're going to figure that out. So what we hope is going to happen with this is that we're going to make the referral process a little more fair and transparent. We hope that we can work people up earlier and then faster and with less travel. We're hoping that with the education and the introduction of our Indigenous patient navigator and our wellness teams that we can provide more culturally safe care, or at least get closer to that. Ultimately, we believe this is going to improve living kidney donation and lead to more transplants. And as a byproduct, because we're seeing people early, I think it's going to get people to the wait list for a deceased donor transplant if they can't find a living donor faster. And hopefully, and arguably most importantly, it will hopefully create a culture of more comfort and more trust in the system where people feel, both donors and recipients feel more supported as they go through. But this is another, I bring up these buts because there's always something that comes up that we need to address. Are we going to know if we're getting any better if we don't have proper data? So we are capturing a lot of data among all the people that are going to be part of this. So we're going to do what's happening to transplant rates, what's happening to donation rates. We're going to talk to people through focus groups and detailed interview of what their experience is and what's working, what's not, as we're rolling this out over the next 3 years. But we don't have a lot of national data. And it's just a plug I wanted to put here that on a national level, as I showed you, our last data is from 10 years ago, and we need to do something to change that. So if I go back to where I started, how do we incorporate Indigenous health into transplant medicine? Our goal is to partner with patients and community. That's what we've tried to do with this project. We've had a clear purpose where we focused it around living donor transplant and trying to streamline that process. And the focus has been not about what happens in community for this, but it's about what are we going to do to make things work better in the healthcare system, because I think we can change that quickly. And we're doing it regionally, but I do think that we've developed a program and an approach that can be generalized across the whole country. So what have I learned so far? Humility is the first thing. I think, the best ideas for this program have come from our patient partners and our elders and the people we've reached out to. And I think that's really key, and that's really reinforced the need for that. I think I've been frustrated at times because at times it feels like there's a lot of talk but no action in terms of our stakeholders and some of the leaders in our groups, in our healthcare system. And so that's been a frustration, but we need to ultimately believe, and I do believe, that we can change this healthcare system, but it takes a real commitment and a real push. It takes money. A big reason why we've been able to do some of the stuff we're doing here is because we got that grant funding that's paying for all of it. And part of that grant funding is actually included a commitment from our funding agencies that they're going to continue it. And then, of course, it takes time. And so this is going to be, I'm excited that this is a good start. By no means is this solving all our problems. It's a start, but it's going to take time to really fix the healthcare system, because our patients aren't just dealing with us here. Even if we fix everything here, it's the entire healthcare system that needs to be fixed. And so if we think about that, there are other things that we're doing that need to address that, because the reality that I started with here is that the challenges span many parts of healthcare, and reworking the entire healthcare system's doable, but it's going to take some time. So there's other things that we're working on in the meantime to kind of take away some of the disadvantage that exists for Indigenous patients, and we can use health policy to do that. So the first example is that we will be seeing the goal is to see every patient who's Indigenous preemptively. So the idea is that before you start dialysis, we know whether transplant's an option and what that looks like. So that means we have to move all the way up. First, we have to get all the backlog done of patients we haven't seen, and then we're going to start seeing people early. So that's one thing that we're working towards. The second is we need a better system for financial and medical support for living donors. We actually heard some of that earlier today. And I think that's really, really key. It should not cost a penny for someone to donate. And that's a principle that clearly is not working in the Indigenous patient population right now. And the third thing is a little more novel and something that we can talk about later. But I think we have to look at the idea that there's a group of patients who deserve a priority on the wait list because of the challenges they face to get there. And so imagine a scenario that we heard similar to earlier today. There's a patient who lives in a remote community, and their only feasible option for dialysis is they have to move or travel 5 hours to go get dialysis. That's not the same as a person who lives in Vancouver and doesn't have to do that. I'm not saying that the person in Vancouver doesn't have a need, but there's a difference there. So for that individual who's coming from that community and having to face that challenge, there is a rationale in my mind to say they should get some priority on the wait list because transplant's going to free them from that. And that's a significant challenge for them. So those are the kind of things that I think we're working on. And so I'll end there. I just want to end by thanking our team, Lisa and Adrian again, and the rest of our team. And we'll do questions after, but thank you very much for your attention.